So when you do have issues with bradycardia, first of all, check out the other things as well. Make sure that there's a good CRT, check your pulse ox, are they getting enough oxygen, and check the blood pressure. If the blood pressure is adequate, all these other things are okay, you don't necessarily need to treat, at least not yet, but still keep in mind and monitor. Obviously, if you're noticing that the animal is under excessive depth, then you want to reduce gas or turn it off all completely and bag with oxygen. And if it's due to drugs or vagal stimulation, you can give atropine or reversal agents. Cardiac arrhythmias, these can be caused by certain drugs, such as your barbiturates, alpha-2s, and halothane. Healthy patients can handle a small amount of cardiac arrhythmias, but geriatrics and patients who already have prior heart issues or heart disease are at risk for more severe complications. It can also be caused by respiratory depression and hypoxia, and any kind of pre-existing heart disease can set your animal up for arrhythmias. Also electrolyte and acid-base disturbances. This can be common in animals also with GDVs, can have cardiac arrhythmias, and thoracic surgery. So you're obviously manipulating the chest area and the heart, and that can induce cardiac arrhythmias. Hypercapnia. So if there's too much CO2 in their system, this could be due, again, to poor anesthetic technique. Is your CO2 absorber need to be changed? Is there not proper oxygen flow? Are they for some reason unable to exhale the proper amount of CO2? So respiratory arrest. So this is the actual stopping, cessation, or ceasing of respiratory effort. As many of you experienced, to induced with propofol, apnea may occur temporarily. Ketamine can cause it as well in barbiturates, but that should wear off as the induction agent wears off. Most likely what you'll notice, you'll also can have issues after prolonged bagging. It's like the body forgets to breathe, so there'll be minimal effort after a prolonged bagging session. You may not need to directly treat it if the heart rate is above the minimal acceptable range. So if they are still circulating blood well, they have a good pulse, membranes are still pink, and the pulse ox is normal. So you may not have to at least aggressively treat it. Remember, if you excessively bag an animal, it reduces the amount of CO2 in their blood, and then the patient doesn't remember to breathe because it's that CO2 in the blood that triggers them to breathe. So a true respiratory arrest, so when those other things, mucous membrane color, heart rate, etc., are also not doing well, is an emergency. Warning signs, dyspnea, so difficulty breathing, or cyanosis. Their vital signs will be abnormal. You won't have a good, healthy heart rate, pulse, CRT if they're in true respiratory arrest. The pulse ox rapidly falls to 90% or below. And at this point, you do need to bag, and you need to continue bagging until the vitals return to normal, because you have to make sure they are getting enough oxygen, that it's circulating through their body. You can stop once their vitals return to normal for about 15 to 30 seconds to see if they start to breathe again. Sometimes it may take a little bit longer, but just continue to monitor those vitals, and as long as they're in a good shape, you can pause. Obviously, if they don't breathe after a prolonged period of time, or the vitals start to drop again, you have to continue bagging them. So, when you have respiratory arrest, obviously tell the vet. Check your ET tube, or if they are not yet intubated, get it in place and get them on 100% oxygen. When you're learning your CPR, airway, that's your ET tube. Check for a heart rate. Make sure if they are on a vaporizer that you turn it off, and make sure that there is oxygen flowing and it's adequate. Again, check your ET tube. Make sure that is in the correct location and that the oxygen is flowing through it. Continue to bag them. You can give them fluids or bump their fluids a little bit. You may need to give them emergency drugs, and remember to keep your patient warm, because hypothermia can complicate everything, and that can be a severe side effect of this as well. So if they go into cardiac arrest, cyanosis, difficult breathing, respiratory arrest, and prolonged CRT and arrhythmias, there will be no heartbeat, no QRS complexes, no arterial pulses. Their blood pressure will be below 25. Their mucous membranes will turn gray or blue, and they'll have a prolonged CRT. You may see their pupils widely dilated and that corneal reflex is absent. So cardiac arrest looks, imagine pretty much that stuporous or beyond that state, not even stuporous, sorry, comatose state, like a really deep anesthesia. They will not be breathing other than potentially those deep, weird agonal breaths. So this is when you start CPCR, cardiopulmonary cerebrovascular resuscitation. You have to be careful and fast because brain damage will result if oxygen is not established within 4 minutes. Ideally, if possible, you have 5 staff members participating. Obviously, you guys will be learning about this a little bit more during CPR, but ideally you have someone doing chest compressions, bagging, checking the pulse, drawing up drugs, and recording. Sometimes you don't have that many people, so if nothing else, if it's only you or it's only you while you're calling for help, start compressions and give them intervals of breaths. So the most important part of the ABC is the circulation. Make sure they have that patent airway, they're breathing or getting a breath, but then circulating the blood and oxygen around their system. Because you can be pumping all the oxygen you want, but if it is not circulating to their vital organs, then they will most likely die. D is drugs. And yes, so the most return of spontaneous circulation, that's the ROSC. You need to keep the oxygen circulating through their body in order for that to even be a possibility. So remember, when performing chest compressions, the rate 120 per minute. You'll learn in your course where exactly to do it. Can depend a little bit on the size of the animal. You want to do ideally 2 minutes continuously and give them a breath every 6 seconds. So that's 10 breaths per minute. Obviously, like I said, if you're the only one doing it, you just have to pause and give that breath, but then keep pushing, keep performing your chest compressions. Drugs depends on your rhythm diagnosis. So recovery, if an animal goes into cardiac arrest, they're going to afterwards, if they wake up or recover, require intensive care. It's very common for them to get another cardiac arrest within 24 hours. So it's really important that you monitor blood pressure, blood gas, pulse ox, ECG, capnography. Often secondary to cardiac arrest, you'll have pulmonary edema and cerebral edema. Oh, and as a final note, often, sometimes animals that do have cardiac arrest do come back, but it's not always, long-term things don't usually work out very well. Not that it's not worth trying. Obviously, the younger and healthier an animal, the better your chances, but I can't remember the exact statistic, but it's not very good that they won't have another event and then end up succumbing. Okay, so what are some problems that occur during the recovery period? We've made it very clear that you don't stop monitoring once you turn the anesthetic gas off, that this is actually one of your most serious, important times to pay attention to your patient. So like we've already discussed, regurgitation during anesthesia or quite frequently post-anesthetic vomiting. As they start to come out of their anesthesia, they tend to vomit. So you have to be there, make sure that hopefully the cuff is still inflated, that you can tilt them down. If you've already extubated, that they still don't accidentally aspirate. This is a chance for seizures and also some excitement as they're coming out. They may go back through that excitement phase. Ketamine kitties, can be pretty scary to watch flop around. Dyspnea, they may start having difficulty breathing, especially your brachiocephalics. And just in general, a prolonged recovery, especially if they had complications during anesthesia, hypothermia, etc. Just wrong way. So regurgitation, this is a passive event that can occur during anesthesia, especially if their head's down and you've been working on their stomach. Again, having that cuff inflated on the ET tube, and you can suction a material out of the oropharynx. Vomiting is an active event, so this is the actual gagging, retching period. This is most common either in a recovery period or if you've given them certain pre-meds. If you're concerned about aspiration, you're going to be watching for dyspnea and cyanosis. If pneumonia develops, you'll see a fever, increased respiratory rate, increased lung sounds, respiratory effort. So treatment, if the patient becomes unconscious, You can place an ET tube. You want to make sure that head is lower than the body. A lot of our tables will actually tilt, so that way you can drain fluid out and try to suction fluid from the oral cavity. So if you have an unfasted patient, so this is the emergency situation where the animal comes in, your GDV, your C-section, etc. Rapid induction and intubation. Adequate ET tube size, make sure it's big enough so that when the cuff isn't fully inflated, it prevents vomiting. Avoid head down positions in surgery. That's a good way to drain at the end if they do vomit, but you don't want to encourage it. Have suction available in case they do either regurge. And you can put antiemetic drugs on board, such as metoclopramide or miripetant. So another possibility is seizures and excitement. These are two different cases, so you have to make sure you know which is which. So seizures is spontaneous twitching and uncontrolled movement of the head and limbs. This can also be triggered by sound or touch. They can get hypersensitive, and loud noises, touching them, even light, you have to be a little bit careful, can cause them to seizure. So sometimes keeping things quiet, keeping things a little bit darker. This can be induced by ketamine, myelography, obviously epilepsy, or if they end up having a hypoglycemic episode, so their blood sugar drops too low. Excitement, this is spontaneous paddling and vocalization, can occur after barbiturates, especially in geriatric animals can have problems with this, and also high doses of opioids without tranquilizers. So if you witness either a seizure and or excitement, I'll let the veterinarian know. Eliminate whatever stimuli, again, quiet, darker, less touch. Provide adequate analgesia, make sure there's pain meds on board. If it's seizures, you can give diazepam, and you may even re-anesthetize with propofol. Maybe not to a full anesthetic depth, but definitely to a deeper stage. And then monitor them to make sure they don't hurt themselves. Also be aware of things like hyperthermia. They can get too worked up and hot, and monitor for cyanosis, make sure they're still adequately oxygenating. So dyspnea during recovery, this is the most common reason animals die during recovery. They get some kind of upper airway obstruction, usually after intubation. We've already discussed brachiocephalic dogs and their problems. Cats have issues with laryngospasm. It's not just an issue for induction. A lot of you dealt with that trying to induce your cats. That's why you would use a little bit of the lidocaine. But even when you remove the ET tube, it can stimulate the closure of the laryngeal cartilages. Also, they can get swelling in their larynx, edema, from repeated intubation attempts. So that's why you don't want to just keep hammering back there with the tube. If you're not being successful, try a different approach so you're not keeping repeatedly intubating and jamming the tube against the back of their throat and potentially causing damage that will affect them later. So clinical signs: stutter or wheezing, gasping, exaggerated thoracic movements because they're having to work harder to push air out and bring it in, and then upward movement of the head during inspiration, like they're trying to gulp air. Differentiate from growling, which is primarily heard on expiration. Check their mucous membranes and their pulse ox. If they're pink and greater than 90% oxygenation and the obstruction is only partial, it may resolve without treatment. Keeping them quiet, keeping them calm, but make sure they are getting enough oxygen. It's a good time that you may need to give them a little bit of oxygen. Maybe if you have an oxygen cage or do some flow by. Be careful masking because it may stretch them more, but getting more oxygen on board. If they are cyanotic or their O2 saturation is less than 90%, you need to try to re-intubate, possibly a tracheostomy if you can't intubate. And you will probably have to keep them anesthetized for 2 hours and give them drugs to reduce any swelling. You don't want to wake them up too soon because then everything will swell up and close again. So prevention, again, good intubation technique, being gentle, using the lidocaine, and extubate fairly early in cats before laryngeal reflex returns, so that way it's not getting tickled.